The World Health Organization's inclusion of complex PTSD in the ICD-11 represents a significant advance in clinical science. The medical establishment formally validated that trauma is frequently relational and cumulative. It recognizes that damage often stems from repeated disruptions in attunement within relationships of dependency. Yet, this vital recognition leaves a structural gap. Prevailing psychiatric frameworks are designed to diagnose distress imported from the outside world. They possess almost no capacity to measure or even account for harm generated within clinical systems themselves. The institution is highly fluent in labeling the damage inflicted by families, partners, and society. But when the injury originates from within the treatment setting, the diagnostic lens fails. This structural failure creates a specific phenomenon known as the iatrogenic breach. Modern psychiatry has finally learned to identify relational trauma, but it lacks the mirror required to see when its own administrative mechanics actively reproduce those exact injuries. Clinical professionals are extensively trained to identify and navigate alliance ruptures. In standard practice, these ruptures are viewed as expected interpersonal friction. They are temporary misalignments between patient and provider that require mutual engagement, open communication, and shared repair. We must ask what happens when a patient's distress is a reaction to a structural, systemic invalidation, rather than a simple interpersonal misunderstanding. An iatrogenic breach occurs when an individual's lived experience is systematically reinterpreted or subordinated. The clinical encounter stops functioning as a site of healing and instead operates as a site where clinical authority displaces the patient's own reality. Applying standard interpersonal repair protocols to a structural epistemic breach is ineffective. Treating a systemic harm as a mere communication error actively exacerbates the patient's injury. Clinical care is built on a foundation of dependency. The individual relies on the relationship with their provider for physiological regulation and meaning-making. This required dependency inherently constrains the patient's options. Disengagement carries significant perceived or actual risk, effectively trapping the individual in the care environment, even when that space feels unsafe. In a functional clinical loop, the patient expresses distress. The clinician engages with that distress as meaningful communication, and together they co-create an understanding to resolve the friction. That functional loop relies entirely on a single fragile condition. Both parties must view each other as credible narrators of reality. When this mutual credibility collapses under the weight of high dependency, the resulting psychological injury mirrors the core mechanics of developmental trauma. The breach is initiated by a specific structural barrier, asymmetrical epistemic power. This imbalance creates the exact conditions for epistemic injustice, being wronged specifically in your capacity as a knower of your own lived experience. Philosopher Miranda Fricker identifies the first mechanism of this harm as testimonial injustice. When a patient attempts to report that the treatment itself is causing damage, their account is structurally subordinated. The account is filtered through diagnostic expectation. The report of harm is reinterpreted by the clinician as distortion, symptom expression, or a lack of insight. The second mechanism is hermeneutical injustice. Clinical systems generally lack the approved interpretive frameworks required to understand institutional harm or coercive care. Because the institution cannot process its complicity, the provider translates the patient's complex relational experience into pre-existing diagnostic categories. The context is collapsed into pathology. Through this mechanism, epistemic injustice rewrites reality within the clinical record. The patient is stripped of their agency, and the institution achieves this without ever breaking formal protocol. Once credibility is diminished, epistemic injustice locks the patient into a recursive feedback loop. The patient will naturally attempt to correct the inaccurate clinical record and advocate for their reality. However, their previously diminished credibility instantly taints this new expression of concern. Self-advocacy is incorporated into the clinical narrative as further evidence of dysfunction. The attempt to escape the mischaracterization is used to confirm it. Over time, this repeated non-recognition contributes to the gradual erosion of the patient's self-coherence and internal organization. This process of recursive erosion does not require malicious intent. It is the natural output of standard practices operating within existing constraints. This clinical phenomenon aligns closely with sociologist Evan Stark's frameworks on coercive control. Stark demonstrated that systems of domination operate by stripping away autonomy through gradual, microscopic restrictions, rather than relying on discrete acts of force. Within the therapeutic encounter, these mechanisms of control are enacted through epistemic force. Standard administrative boundaries and risk management imperatives function as the invisible bars of the cage. When administrative convenience supersedes relational accountability, the erasure of the patient's lived experience becomes a structural inevitability. The consequences of this breach do not remain contained within the consultation room. The fallout disperses through the individual's life long after they leave. Trauma literature confirms that harm is radically intensified when it occurs in relationships explicitly expected to provide safety and recognition. One major downstream effect is a deeply diminished sense of self-trust. Patients lose confidence in their ability to accurately interpret their own internal states. There is also a severe disruption of the personal narrative. The constant overriding of their experience destabilizes their capacity for meaning-making. These structural outcomes mimic the exact symptoms of relational trauma that the individual originally entered treatment to heal. Consequently, individuals who suffer an iatrogenic breach often develop a dense protective barrier against re-engaging with future care. Mitigating this relational harm requires practitioners to address both interpersonal habits and structural frameworks. The primary requirement is the recognition of epistemic agency. Clinicians must treat patients as credible contributors to understanding their own reality. Clinical interpretation must remain responsive, rather than overriding. The secondary requirement is epistemic humility. Clinical expertise operates within strict limits. Institutions must overtly recognize these boundaries, particularly when dealing with complex or contested experiences. Ordinary therapeutic rupture is common and expected, but dismissing patient-reported harm or prioritizing procedural compliance over relational repair is an active ethical failure. Without confronting the mechanics of the iatrogenic breach, mainstream mental health care risks doing nothing more than reproducing trauma under the authority of treatment.